merciful and the most compassionate, and Prophet Muhammad, peace be upon him. Hello everyone, this tutorial is provided by IHB Hearing and Balance Center. IHB Hearing and Balance Center is an audiologist located in KFS, Egypt. IHB Center serves KFS and surrounding areas with exceptional hearing imbalance service, providing hearing imbalance testing, care, and solution. Also, IHB Sooner provide complete basic audiological evaluation, behavior observation audiometry, visual reinforcement audiometry, play audiometry, and conventional pure tone audiometry, and also provide impedance test battery, both high frequency and low frequency tympanometry, EPSI and contralateral reflex, and a station tube function test. Also, HP Center provide a complete advanced audiological evaluation, ABR, and audioacoustic emission. And also, HP Center provide all complete diagnosis rehabilitation of dizziness, imbalance, and vertigo. In order to keep your balance, it requires input from your eyes, your sense of touch, and most importantly from your ears. This is the room of video nystagmography, and this is the room of vestibular rehabilitation. Also, IHB Center provides tinnitus retraining therapy and finally provide cochlear implant mapping up to optimization. So let's move on our tutorial today, case presentation by HB Center Teamwork. The first case, the history of the first case, female patient 24 years old, complaining of tinnitus and hearing loss in both ears of 4 years duration. What about her basic audiological evaluation? Bilateral, as we see here, it is bilateral moderate conductive hearing loss with coherent notch at 2 kHz per conduction, with excellent speech discrimination, and bilateral type A tympanometry with absent acoustic reflex. So, what is the diagnosis, differential diagnosis, and lines of treatment? When we look here, we have a bilateral moderate conductive hearing loss with type A tympanometry and excellent speech discrimination and absent acoustic reflex. It is a typical case of otosclerosis. So, what is otosclerosis? Otosclerosis is a hereditary disease of the aortic capsule characterized by replacement of normal compact bone by spongy bone, which is otospongiosis. The cause is unknown, but it may be hereditary. What about the incidence of otosclerosis? It is more common in female middle age. What about the otoscopic examination is normal in most cases and rare. Sometimes the drum may be flamingo red in color in the active otosclerosis. So when we do investigation, we do pure tone audiometry and tympanometry. The pure tone audiometry will reflect a coherent notch at 2 kHz per conduction. The tympanometry may be type AS, which is a stonic curve, or type A. What about the differential diagnosis of the otosclerosis? Maybe congenital speedial fixation, maybe osteogenesis imperfecta, which characterized by epilusclera and multiple fractures. Maybe all causes of conductive hearing loss with intact tympanic membrane, like secretory otitis media, adhesive otitis media. But in secretory otitis media will be type B tympanometry, and in adhesive otitis media may be type C or type B tympanometry. So, what is the lines of treatment of otosclerosis? Maybe no treatment of airborne gap less than 25 decibel, or hearing aid fitting or surgical management with stapedectomy or stabidotomy, and sometimes medical treatment sodium fluoride used. Let's move on the second case. Male patient aged 54 years complaining of tinnitus, diminution of hearing in the right ear with sense of rotation. His basic audiological evaluation reflecting a unilateral, low-frequency rising sensorineural hearing loss with bilateral excellent speech discrimination and bilateral type A tympanometry. So, what is possible diagnosis, investigation, and lines of treatment? When we look here, unilateral, low frequency, sensorineural hearing loss rising with excellent speech discrimination. So the possible diagnosis here is Meniere's disease or endolymphatic hydrops. So what is endolymphatic hydrops? Endolymphatic hydrops or Meniere's disease is the distension of membranous labyrinth with endolymph characterized by recurrent attacks of vertigo, deafness, and tinnitus. What is it causes due to excessive formation of endolymph by striae vascularis or lack of drainage by endolymphatic sac. The exact cause of Meniere's disease is unknown, but it may be autoimmune, viral infection, allergy, salt and water retention, or sympathetic overtone. So what is about the incidence of Meniere's disease? It is usually unilateral. It is more common in males and around age around 50. What is the clinical picture? Recurrent attack of the following triad: vertigo, which lasts few minutes to few hours, and in between attacks, the patient is normal and associated with nausea, vomiting, and nystagmus. Deafness, which is a sensorineural hearing loss, it is sensorineural hearing loss, low frequency, and characterized by its feel like when hearing loss associated with hypersensitivity to loud sound, which is positive recruitment. So, what about investigation needed? As we did here, pure tone audiometry reflecting a fluctuant sensorineural hearing loss, low frequency. We can do electrocochleography. We can do a glycerol test, positive glycerol test, which glycerol is diuretic. The hearing will be better after intake of glycerol. The vestibular evaluation by video nystagmography, we can do a caloric test and will reflect a caloric hypofunction or the caloric hypofunction or unilateral caloric weakness. So, what is the lines of treatment of Meniere's disease? During attack, complete bed rest or sedative as diazepam, antiemetic as chloropromazine. In between attacks, reassurance and salt and water restriction, diuretic like furosemide, and vasodilator like beta-histine and anti-vertigo drug like Dramamine. Case number 3, Male patient aged 46 years complaining of tinnitus in right left ear 7 years ago. His basic audiological evaluation reflecting a high frequency in the hearing loss and sonora sloping in the left ear with poor speech discrimination and absent acoustic reflex in the left ear. So what is possible diagnosis here? What is possible diagnosis here is a retrocochlear lesion or acoustic neuroma or vestibular schwannoma. As we see here, it's a very poor speech discrimination. In the left ear, it is a unilateral sonora hearing loss. So, what is vestibular schwannoma or acoustic neuroma? It is a benign tumor arising from the Schwann cells of the vestibular nerve in the CB angle in cerebral open 10 angle. So what's the clinical picture of the acoustic neuroma or vestibular schwannoma? It is a unilateral sonora hearing loss with tinnitus, vertigo. Vertigo here is rare, as it is a gradual, very slowly progressive. So compensation occurs. Loss of corneal reflex due to trigeminal nerve affection. We will notice in the terminal stage increased intracranial tension. So, when we do a pure tone audiometry, we will find a sensorineural unilateral sloping hearing loss with very poor speech discrimination. And so, what is about the differential diagnosis? What about the differential diagnosis of the differential diagnosis of the acoustic neuroma or vestibular schwannoma? Uh, Maybe a meningioma, congenital cholesteatoma, arachnoid cyst. So, what about treatment, surgical excision, or radio surgery by gamma knife if it is a small tumor? So let's move on. Case number 4. Male patient aged 48 years complaining of tinnitus and diminution of hearing in left ear 4 days ago. He has erectile dysfunction. The endocrinologist described syndrome trait 2 weeks ago. This as has basic audiological evaluation, pure tone audiometry, as we notice here, is severe to profound sensory hearing loss in the left ear with very poor speech discrimination. So, what is the diagnosis of that case? It is a case of sudden sensorineural hearing loss. So, what is the lines of treatment here? By corticosteroid, intratympanic and oral steroid, hyperpanic oxygen, vasodilator, and other issues. Case number 5. Male patient aged 42 years complaining of poor speech discrimination, especially in noise. And when we did a pure tone audiometry, it is high frequency bilateral sensorineural hearing loss with very poor speech discrimination. And bilateral type A tympanometry. So it is an important case. What's the diagnosis? Here it may be a case of deuteroneuropathy spectrum disorder, but deuteroneuropathy spectrum disorder more in the low frequency with very poor speech discrimination. Maybe central-auditory processing disorder, differential diagnosis, maybe central-auditory processing disorder, maybe bilateral vestibular schwannoma in case of neurofibromatosis too. Case number 6. Male patient aged 62 years complaining of right diminution of hearing since early childhood. 1 month ago, he came to IHB sooner complaining of left ear diminution of hearing and fullness. He is a very heavy smoker. As we see here is right total hearing loss and left mother and left mother mixed hearing loss with type B tympanometry in the left ear. He is old age with unilateral secretory otitis media. So, what is the diagnosis? As we said, is the unilateral secretory otitis media. It is unilateral secretory otitis media in old age with heavy smoker. The important ENT consultation for nasopharyngeal examination.